I can't talk to you right now. I'm on the webinar.
Welcome, everybody. This is Alex McDevitt with the RHSC Secretariat. We will give everyone a couple minutes just to get their audio up and running, so please bear with us. All right, everyone, welcome again. This is Alexandra McDevitt with the RHSC Secretariat. Just a few logistics before we get started. All attendees are in listen-only mode, and throughout the webinar, you will be able to write your questions into the questions box that appears in your dashboard. After the presentation, we will have ample time for question and answer, so please write them in throughout the presentation or once we get to that question and answer bit. We're really excited to hear from our presenters today, a team of colleagues from Gynuity Health Project. This webinar is a presentation of an innovation fund through the New and Underused Reproductive Health Technologies Caucus, the NERC Caucus, and it's titled Increasing Access to Mifepristone, Paving the Path for Registration and Commercialization for Additional Indications. With that, I will welcome Jennifer Blum, who will get us started.
Thanks, Alex. Can everyone hear me? I guess I can't really do that well, but okay. So good morning, or good afternoon, good evening. I, myself, and my colleagues Laura and Aisha are going to present today on our Innovation Fund grant, which had several components, as many of you know, included some interviews with global stakeholders and country-level stakeholders, and also production of a document on this topic. And so we've split the presentation into three parts, so we will be switching presenter as we go forward. So next slide. Do I switch the slide or? Oh, thank you. So as Alex mentioned, Gynuity has an innovation grant for this topic, which is to explore interest in mifepristone for other indications and viability of that as a way to increase access to mifepristone globally. And we're specifically interested in being able to, the possibility of registering mifepristone for other indications in countries that have no registered product, as a potential alternative indication that could bypass hurdles. Also in countries with limited markets, perhaps for the commonly registered induced first trimester abortion indication as a way to increase demand and market sustainability. And also in countries where mifepristone is underused, we believe this strategy could reduce stigma and really provide an entry point to be stocked at facilities, and for example, to be stocked in different places within hospitals than perhaps it's currently being stocked and accessible to other types and levels of providers. Next slide. So as I mentioned in my previous slide, or started to mention, the number of countries with mifepristone is increasing, in places with restrictive abortion laws, access remains challenging. And we can particularly see this on some of the maps that map out where mifepristone is registered. And certainly when we look at Latin America, for example, or parts of sub-Saharan Africa, although registrations are increasing, it's still very much correlated with where there is legal first trimester abortion and a bigger market. So we find a persistent commodity gap in these restrictive climates due to these barriers, lack of registration, or in some places, lack of appropriate distribution, commercialization, as we'll see in our country level findings, and really the need to create demand, both by providers and by users, to know that the drug is available and how it can be used. For our project, we were interested in four different clinical indications. All of these indications are legal in most settings, which we believe means that the drug registration would not pose the same problems as we've seen with many of the labeled products. And certainly we'll hear a little bit about that in discussion of the country level findings in West Africa. And of note, because many people have asked this, is it possible or has this been done before? And just of note, the originator product, Paving, registered in France and now widely throughout Europe and elsewhere, in fact, is already labeled for other reproductive health indications. So the sort of the standby has always been available, but it hasn't been made perhaps fully utilized. Next slide. So these are the indications up in the box in red that are of interest. This lists all the indications that we know that mifepristone is being either used or studied for. So treatment of early pregnancy loss, treatment of IUFD, second trimester abortion, cervical preparation prior to surgical abortion. Those four indications, there's a large body of evidence, we believe, already supporting that. And then there's a number of other indications for which mifepristone is used. Uterine fibroids, emergency contraception. It's a registered product in many places, as many of you probably know, at a lower dose for EC. Cushing's disease, and then different dependence issues and labor induction. We did not focus on these indications in our project because they require a different tablet size, and we're interested in exploring indications that would be a segue to registering the same 200 milligram tablet that's used for mifepristone for early medical abortion. Next slide. So this just gives an example, just really quickly to show you. At the top, we have the language from the mifeprex label in the U.S. And just one thing to note about this, these labels can, of course, change. And many of you that are familiar with what's happened with medical abortion in the U.S. know that just a few years ago, this label was changed to increase the gestational age based on clinical evidence through 70 days. And below is the language from the Mifegen registration for many years ago in France. And as you can see, there are already 4 indications labeled there. So next slide. So we did, about 6 months ago, we started with a global assessment, and we conducted interviews with MSI, PSI, Danco, Line Pharma, NARI, IPPF, DKT, and the Concept Foundation. And this just gives some highlights of what we found from those interviews. Overall, we found a high interest in exploring labeling of other indications for mifepristone. A little bit of a mixed knowledge of the available evidence, and that I think had to do often with needing to talk to multiple people at some of the organizations because there's, the medical person versus the marketing person. But I'd say a mixed knowledge overall of the available evidence and different understandings. Again, this relates to the type of people we were talking to at different organizations, but different levels of information as to the requirements to add a labeled indication. And unfortunately, because we were hoping that this would lead to some consensus around one of the indications, we actually found no consensus on the most promising indication of these 4. Many of the actors and stakeholders that we spoke to mentioned that they had insufficient time, human resources, and money to pursue this. And I remember one in particular mentioned that this is an area of interest that's come up to them many, many times in meetings at the strategy level, but they just haven't really had the time or wherewithal to kind of pull together a strategy plan. Next slide, please. So again, in terms of what were the indications that were most widely known, incomplete abortion, missed abortion, second trimester abortion, and intrauterine fetal death were all kind of, all of them were known, and there was no most commonly known indication. There was some interest in some of the settings in labeling a product specifically for menstrual regulation, following a little bit on the Bangladesh model. The next part I already mentioned earlier, but I'll just point out one thing when we talk a lot about combi packs, is that one of the respondents we spoke to said it would actually be really helpful to have a standalone MIFI product for a new indication. So instead of adding an indication to an existing product and having one product that's labeled for multiple indications, or having a combi pack that's labeled for multiple indications, to introduce into markets sort of a different, maybe branded or labeled mifepristone product for one of these other indications that then could be used through, education, demand creation, and other strategies, along with existing misoprostol at the country level, and that there was some interest in that as a strategy to sort of increase access. Next slide. So we asked a little bit about the challenges and priorities, why we would even do this and where the efforts should focus. And what we found is that, many of the stakeholders we spoke to, and certainly this was what initiated our interest in this area and then was sort of reiterated through these stakeholder interviews, found that there was just a number of political barriers at the country level, making access to formal registration and availability of products for induced abortion very difficult. There were also some concerns about market size, particularly the small market, and whether or not it was cost effective or economically feasible to maintain a product on the market for just this one indication. And some of the countries with smaller populations, fewer women have experiencing complications, unsafe abortion, etc. And that some manufacturers just don't view mifepristone as a profitable product. We were trying to glean from these interviews where future efforts should focus, and again, to help perhaps guide or impact our selection of countries to move forward with, but also just overall in terms of where this could have the greatest impact. And again, as with the other things, we really had a little bit of a mixed bag of feedback. Some of the respondents were very much just said, oh, wherever donors can support us, we would love to do this. Others specifically honed in on West Africa and South America as areas where there is the largest need for this type of work. Next slide. So I'm going to turn it over now to my colleague Aisha, who's going to talk a little bit about the country level assessment.
Good morning or good afternoon. So in order to assess the interest in mifepristone for other indications and to gather perspectives on what might be viable options moving forward, we did conduct assessments, as Jennifer mentioned, at the country level in 7 different countries. And so we conducted a total assessments in a total of 6 countries, which were Burkina Faso, Colombia, Kenya, Latvia, Pakistan, and Senegal. And through these assessments, we attempted to have some type of regional representation, including places where no mifepristone product was currently registered for any indication, in places where abortion was legally restricted, and in places where there was known interest in exploring alternative indications for mifepristone. We also purposefully included countries where abortion is legally permitted. Mifepristone has already been registered or already being sold on the market, but where the market is not necessarily stable. So we conducted the interviews with key stakeholders, including staff from the Ministry of Health or drug and regulatory bodies, healthcare providers. We did include some actual abortion providers, and country level staff of some international NGOs. Next slide. So now just give you, just go over some highlights and brief summaries of the results of our assessment, just to give you a sense of some of our findings for each of the countries. Excuse me. So in Senegal, the abortion law is a bit unclear and kind of confusing. The abortion is completely banned by the criminal code, so legally it is a criminal offense. However, there's a medical ethics code where it's permitted, and that's to save a woman's life in the case that 3 doctors come to the agreement that it's necessary to save a woman's life. As in all of West Africa, abortion is highly stigmatized, including with the medical profession, and especially when it comes to first trimester abortion. We had one of our respondents say that first trimester abortion is not seen at all as something that's medically necessary, and so based on that fact that most doctors won't conduct abortions for that reason. It's also kind of reinforced. We heard a lot during in medical schools and in their teachings and amongst the medical community that it is just something that they should not be associated with. But on the other hand, it's known that abortions are widely performed and services are available. And we also learned that several medications are already available in pharmacies and they're used for abortion, bought and sold for that purpose. Right now, as we know, there are no real efforts to register mifepristone, but of course, misoprostol is registered and used widely in the country. In terms of potential benefit, there was an agreement that an alternative indication would be a good way to introduce mifepristone into the country, especially that there currently is no product and that people are not necessarily aware of what mifepristone is or what the label would read. They talked about legal registration of a MIFI product, having an indication that would be illegal, that would be covered under legal, would provide a cover so that pharmacists and providers would feel safe using the medication. And kind of in all the respondents kind of echoed this idea of creating a legal cover, a need for a legal cover so that the women and providers would feel protected, because we know that even someone just referring a woman is at risk of jail time. So that legal cover was kind of a recurring theme. There was no consensus on which indication might be the most useful, but the respondents did agree that multiple indications would most likely result in increased use and availability. Of course, they also agreed that the indication should be non-abortion related so that it wouldn't cause controversy. So kind of in the realm of safe motherhood. One of the respondents mentioned that the strategies to register misoprostol for PPH and PAC were successful just because of this reason, because they were not politically controversial. So the thought was that the same could happen for mifepristone. In terms of challenges, abortion or any drug that's associated with abortion is a highly controversial topic. No one wants to talk about abortion openly. Registering a product for an indication that's not legal is considered risky, and this kind of came up in several of our conversations. In fact, one of the representatives at the Ministry of Health said that a label for first trimester abortion or a label that includes an indication for first trimester abortion was not at all acceptable, and it was a blatant defiance of the law. So they talked about approach, whatever the approach, being kind of subtle, even though it's known and it's accepted that abortions occur and that it's provided, that we need to be very cautious and have kind of a subtle approach, and providing alternative indications would be one way to do that. Next slide. So the context of abortion in Burkina Faso is similar to other Francophone countries in West Africa. It's legally restricted, highly socially stigmatized, and recently there's been a little bit more of unrest and kind of making abortion a little more socially taboo in Burkina Faso, because there are civil society groups and there are religious leaders that spoke out against it. So everyone at this point in time is a little more cautious. when they're speaking about abortion. For the law, it's legal in cases where it's necessary to save the mother's life, and in cases of rape or incest or severe fetal malformation. So it does leave more legal openings than in Senegal, for example. And there's also been a recent change to the law that reduced the number of providers that were required to approve abortions from 2 to 1. And in addition, physicians are also able to delegate to midwives. So performing legal abortions has become easier. And as in other countries, it's known that abortion is provided, but it's not necessarily discussed. It's kind of kept quiet to not bring too much attention. One of the respondents said that everyone knows, but no one wants to talk about it. Currently in Burkina Faso, there are 2 Combipack products that are currently registered, but they're not available or sold in the public sector. In terms of potential benefit, the respondents did agree that new indications might make things easier and increase access. For example, new indications could help to reduce backlash if the medications were deemed medically necessary in nature. So first trimester was not perceived as medically necessary. So there's an interest in kind of looking at indications beyond this first trimester. We are conducting a study on second trimester abortion in Burkina Faso, and so there's interest around that as a potential entryway or something that could be included on the indication to kind of move away from this talk and the taboo that's associated with the first trimester. There was no agreement on what the most useful indication or what the most useful new indication might be, but the respondents kind of agree that it should be one that causes the least disruption, or it should be framed as something like a life-saving drug, just to kind of shift the conversation a little bit. They were pretty much all in agreement that it should be something that is non-abortion related. I think Jennifer mentioned earlier discussions around menstrual regulation and as being one of the potential indications. And there was kind of interesting conversations. One of the people I talked to thought that it would be a great idea. Somebody else thought that it might be a terrible idea. And so there was kind of 2 opposing views on whether menstrual regulation might be a good approach. One thought that it might be an ideal approach to increase access for young women and girls. The other side of the coin was that maybe this would be seen as either a front for abortion or something really deceptive as an approach, and that people might be offended by that approach. So there's still more exploring to do around that. For the challenges, because of the social and political environment, widespread marketing and distribution of mifepristone for first trimester abortion has been difficult. We want to pay attention to not bring negative kind of attention to a product since it's already available and the environment is kind of politically and socially sensitive. So just there should be a little bit of caution around that, how to talk about something that already exists and not bring too much negative attention to it. Next slide. So in Kenya, the law in Kenya allows abortions when the mother's life is at risk. And in talking, in talking to our respondents, the practice of abortion seems to be available on demand, even though the criteria is quite strict in its definition. But also, like in other countries, it's not something that's widely talked about. It's done, it's provided, it's offered, it's just not talked about. Right now, there are currently 3 combi packs that are registered in Kenya, and the first product was made available in the country in 2013. And both mifepristone and misoprostol are on the country EML, but they're listed separately. And we know that the combi packs are available, widely available in the private sector, but not in the public sector. So in Kenya, a little bit different than in Senegal and Burkina, the informants generally did not perceive a potential benefit for registering mifepristone for other indications. They kind of thought it's available, it's being used. Do we need to make any changes to that? But on the other hand, they did think that adding additional indications might make it easier and potentially increase access in the public sector. So there was acknowledgement about the potential benefits to having additional indications on the label. And one of the respondents mentioned that a new label might serve also as a training for providers. So the label would ensure that it kind of had the indications and instructions for providers so that they would know how to administer the drug, because there was a little bit of fear around providers not knowing exactly how to administer or to provide these drugs. And in terms of challenges, the combi pack is widely used without much attention. So the concern again is for potential backlash if the label change brings more attention to the drug, especially now since it's being used for indications that's kind of larger than what the law permits. So that's for Kenya. I'll hand it back over to Jennifer to give you an overview of the remaining countries.
I think if you're speaking, we are having trouble hearing you. If you could unmute. Laura, I think you've self-muted. If you could just click the microphone button on the dashboard, you should be able to unmute. Jennifer, it looks
Can you hear me now?
Yes.
Okay. Sorry, everyone. I had a nice conversation with myself there for a few minutes. I had the pleasure of getting to speak to a number of colleagues in Pakistan, which was really fun for me, having worked there years ago, and to hear what's going on there and maybe want to make a trip there. But anyway, I talked to a number of people in the Pakistan Alliance of Post-Abortion Care, which is sort of leading a lot of the work around provision of abortion and post-abortion care in Pakistan and others. And just to give an overview of the context, abortion is available by law in cases where it's needed to save a woman's life or a necessary health treatment. And misoprostol is registered in Pakistan for both PAC and PPH, and there is a locally manufactured product that's available and of high quality. The understanding that we get from the stakeholders that we spoke with and others in the field is that it's widely used by providers as an abortifacient, although it's not registered for first trimester abortion. So when we got to the topic of potential benefit, there was overall agreement that additional indications would be good, but also some mixed reviews, some concerns about potentially, destabilizing the good thing that they have going now with misoprostol. So, for instance, there was some concern about whether bringing mifepristone to market and the mifepristone would be sustainable, given that misoprostol is widely available and very cheap. What would the cost be, and would cost be a variable? And some questions, as I mentioned, by the members of the Alliance for Abortion Care about whether or not this would be a good sort of plan or strategy moving forward, given the fact that misoprostol is available and widely used. That said, overall, as I spoke to more people, the consensus, not the consensus, because not one person wasn't sure, but the feeling of the other stakeholders that I spoke with was that actually this could be a very good strategy for Pakistan, particularly because it would be a way of increasing access to mifepristone on the market, potentially creating more options for providers to use it in different ways. And also it came up, and this very strongly came up from a number of stakeholders I spoke to there, from a sort of women rights choice perspective. They brought up the fact that if women should have access to this medication as they have access to misoprostol, and also that they should have access to choice. And so if we have another method, another drug that can be used that especially could be more effective and with fewer side effects, everything should be done to make this product available. But how to go about this, as I should mention, with respect to the countries in West Africa, would have to be a very clear, country-led strategy, and how to make this happen in a way that wouldn't destabilize the accessibility of misoprostol now. In terms of clinical indication, most people that I spoke with felt that pregnancy failure, and if you could make it a more general indication or a mix of, management, treatment of missed abortion and or IUFD, would probably be the most promising indication for the country. One of the things that was mentioned that I thought was of interest is that several years ago, mifepristone was actually put into the uterine evacuation guidelines. And so as just slipped through, or was put in strategically. I didn't quite get the whole story, but anyway, it is there. And so again, if the product were to become available, there was a sense that it would be easier to be used by providers. So this seemed overall like a promising country and a lot of interest. And one of the features about what's happening in Pakistan is just the very active abortion, post-abortion care community, and sort of willingness to take their country level expertise and the years and years of strategy around post-abortion care, and sort of think about how to move forward with this new strategy in Pakistan. So it was overall a promising country for this. So next slide, please. So Latvia was the one country that very clearly the informants did not perceive a potential benefit or need to register mifepristone for other indications. In Latvia, abortion is legally available on demand until 12 weeks, and medical abortion is legal until 7 weeks, and both MIFI and MISO are registered. Currently, medical abortion is almost exclusively provided through the private sector, and the service delivery volume is low. So many people felt that, the stakeholders felt that while it would be interesting to have alternative indications or additional indications, it wasn't really necessary because they already had a mifepristone on the market. And instead, and providers can use, are authorized and already do use drugs for other indications, or quote unquote off-label is not a restricted issue for them. So they felt that the better strategy there is, rather than focus on additional indications for mifepristone, instead to think about how they could lower the cost, work on increasing access to mifepristone in the public sector, and things that could be done around sort of educating providers and educating the public about this. Another change in guidelines that they recommend with respect to first trimester abortion is to again revise the law to allow medical abortion beyond 9 weeks of gestational age. But overall, not an interest in moving forward with other indications in Latvia. Next slide. So the last country that we conducted some stakeholder interviews in is Colombia. And just to give a little bit of the context, in 2006, as many of you on this call know, the Constitutional Court in Colombia ruled that abortion should be available in cases of rape or incest to save or preserve a woman's life or where the fetus has malformations. And national guidelines have included mifepristone as an option through 10 weeks and mandate that facilities provide abortion at least by referral. And recent guidelines, as I was told by a colleague who ran these interviews, have also allowed use of medical abortion into the second trimester. So in terms of benefit, again, I would say overall there was, the majority of respondents felt that there was a benefit to exploring other indications in Colombia. There was a great deal of interest in exploring the second trimester abortion indication, particularly with respect to the guideline change, and also sort of a segue into making it repositioning mifepristone as a medication for second trimester medically indicated abortions, which, as we all know, less stigmatized. But some stakeholders also did mention the evidence and interest in registering for cervical priming or missed abortion. So one of the challenges that the stakeholders that we spoke with felt is just the lack of awareness that MIFI is available in Colombia in general, even among providers, and certainly also among potential users, and how that affects market sustainability now for the existing indications, and what can be done to sort of increase information and subsequently increase demand, both for use for the first trimester, but also potentially in the future for other indications. There was also some concern expressed by a few of the stakeholders, but not all, about not wanting to rock the boat, given the current administration, and also how, if there would be adequate funding to actually be able to launch such an initiative and carry it to term. Next slide. I shall pass it back to you.
Yes, so in summary, in kind of trying to gauge the interest from the different countries that we conducted the assessments in, so we can say that there's kind of a clear interest from at least 3 of the countries. Maybe 2 countries might warrant further investigation, Kenya and Pakistan, with both of them leaning towards yes, and there, as we both mentioned, there is a lot of interest in exploring additional indications that might be beneficial and might increase access for women. And lastly, one country where there was clearly no advantage right now to exploring an additional indication. Next slide. So for these country level assessments, there was no general consensus on what the most promising indication should be across the countries, but as we mentioned, we did see some consensus within the countries. The respondents had various levels of understanding of what it would take to kind of add, or if we needed to change a label, and what this would mean in the countries. So we would, of course, each of these strategies would need to be defined at a country level, but it was clear that in several of these countries that looking at alternative indications could be a viable strategy, just that this approach would need to be combined with other strategies to give us kind of a better sense of the markets and the context. Next slide. So in terms of next steps, we think that meetings should be held at both the global and at the country level to define the best strategies moving forward with, of course, a particular focus on the countries where there was a clear interest in these alternative indications or additional indications to include on labels. But of course, we know that it's not a standalone strategy. because the label change or registration are kind of just first steps in expanding access and use. So we also need to include strategies that will support knowledgeable, competent trainers, support the health infrastructure, and kind of ensure a predictable drug supply. So we do need to think about parallel strategies that need to be developed along with this label and registration efforts. We would also convene a webinar to improve the knowledge and understanding of mifepristone registration, marketing, distribution, and availability. Next slide. All right. I will pass this on to Laura.
Thank you, Aisha and Jennifer. And hello, everybody. Just as a brief warning in advance, we had a very weird power surge here in New York, which just fried all of our computers. So if I disappear again, then one of my colleagues will complete this presentation, but hopefully our power is stable now. So one of the things that we wanted to do as part of this project is produce a tangible briefing document to help address some of these issues that were identified in the global assessment, particularly around different companies not having the human resources to go into all the evidence base and to research these indications more clearly so that they can incorporate them into their strategies. And so to that end, we have developed a briefing document. I think we initially wanted it to be a one-pager, but we are settled on a 4-pager because there was a lot of information there. And the first page really goes over just some advocacy messaging of how you might want to talk about these expanded indications for mifepristone, about how when evidence supports safe and effective use of a medication, women should be given a choice of options for their care. And this applies to treatments involving mifepristone. We list the indications of interest, as Jennifer went over before, and try to frame things as ultimately each labeled indication for a single pill has the potential to appeal to different stakeholders and expand marketability. So we wanted to proceed with providing a full literature review for all 4 of the indications that we were looking at, since we didn't get a clear consensus on one that should be our strategy for moving forward. So the second page of our document has a little box of evidence for each indication. And it starts with an explanation of the indication so we can be really clear about what we mean by each indication. And that is meant to address some of these issues about the lack of understanding of what these things are, and how they're separated in the literature is not necessarily how manufacturers or how governments think of these indications. So we have a brief explanation of what that is. So for example, the evidence base that we examined on cervical preparation is cervical preparation prior to surgical abortion. That's where we see the Cochrane reviews and the large randomized controlled trials. So then that would not qualify as a non-abortion related indication. And so after we define the explanation of each indication, we give a little summary of the evidence. So if there was a Cochrane review, if there were large randomized controlled trials, if it's in existing international guidelines, then we summarize that there with a list of the appropriate references. We also tried to indicate when there was ongoing research on an indication, and whether that indication, the current evidence supports the regimens in a combi pack, because we know that that was of interest to some stakeholders to add indications to a combi pack. So that's briefly these first 2 pages. Alex, can you go to the next slide, please? And this is just to say that we had a huge number of references during this literature review that we're making available as a zip file on request. So please don't hesitate to contact me and I can send you all of this literature if it would be helpful in any advocacy efforts or any registration efforts. Our current version has 73 references, and we think this is a pretty good review of the literature on these 4 indications. So we'll make this available to anyone who thinks that it could move their case forward. Next slide. The other thing that we pulled together was a pretty simple table of each indication and its status on recommendations and international guidelines. We know that some countries follow the WHO or ARCOG quite closely when they're making decisions around registrations for different drugs. So we list the indication and what NICE, WHO, ARCOG, FIGO say on these indications. And one important thing to note is that early pregnancy loss, which is an indication that appeals to a lot of the people we talk to, is one of the newer indications, and it is not yet on any international guidelines. So the current guidelines do not recommend it. However, IUFD, second try, and cervical prep prior to surgical abortion are recommended on the guidelines or listed as one of the effective regimens. There's a little piece that's not showing here. We do have a tiny paragraph on the other indications that Jennifer mentioned, and a brief on kind of where we are with those, but these are really the four where the literature is the strongest and where we thought that there might be an opportunity to move forward. Next slide. So that's the summary of what we have to share with everyone today, but we do want to thank some people in particular, specifically with reviewing this briefing document. Dr. Paul Blumenthal, Dr. Hilary Bracken, and Dr. Natalie Kapp, who is on the line, were instrumental in helping to make sure that this information was useful and accurate. Also, our colleagues at Gynuity, Ilana D'Zuba and Inga Plates, helped coordinate some of the country level interviews. So we wanted to thank them. Everyone else who participated in our interviews, and RHSC for supporting this work. So thank you to all of those people. So now we'd like to move into the question section, and Jennifer will moderate.
Hi, can you guys hear me?
Yep, we can hear you well.
Yes, we can.
Okay, Alex, are you going to read the questions? I can't. I think only you see them.
Yeah. So I will.
Okay.
Yeah, I can make questions. But before that, I just wanted to say thanks very much for that comprehensive presentation. It was really interesting and thorough, moving through all of the countries with all of their nuances. So thanks very much, and I appreciate, as well as everyone else, that thoughtful presentation. So the first question is from Suzanne Fournier from SIF. And that is, in light of concerns from stakeholders that registration for a new indication may unnecessarily expose MIFI, could there be value in first testing the experience in a more liberal context?
Oh, I think yes.
And I do think there is some interest in this in the US in particular, looking at the early pregnancy loss indication. There is some interest in adding that. But the other issue is that in many places, mifepristone is only known as an abortion drug, so I'm not sure it would add more exposure, but it's definitely something worth considering.
Great, thank you for that. And just a reminder, if anyone has questions, they are welcome to type them into the questions box, which will appear in your dashboard. We have another comment here, not so much a question, from Milka Dina, the RHSC Secretariat lead for FORALAC. And she noted that this would be a very helpful webinar for members of FORALAC, and that if possible, she would like to help produce this webinar in Spanish. I'm not sure if we need to comment on that at this time, but we can follow up with that offline.
Yeah, that's a great idea, Milka.
Yeah, I think it's a great idea, and also we could elaborate more on the findings from Ilana's interviews in Colombia. Maybe hone in on a few key countries that might be of interest and examples for the FORALAC audience. So that's something we can discuss. Thank you.
Great.
Any other?
At this moment,
if I could just comment on the report.
Yes, go ahead.
Oh, I didn't see other questions. I was just going to say, just a reminder, as Laura mentioned, the 4-pager, the 1-pager 4-pager is now finished and available, so we can make that available. I believe we have already around, but we can make it available again to members of this group, and also a full report that will go into more details of the country level findings is in progress, and we expect that to be done in the coming weeks. And so that can also be shared like a written report with everybody.
Great, that sounds awesome. Thanks, Jennifer. We have a couple questions that have come in. We have one from Temple from the Packard Foundation. In the next step section, you mentioned incorporating market stabilization strategies into strategies for registration. Could you speak more about that and what it might look like?
Laura, you want to take that on?
Sure.
Are you on still? Okay, yeah.
I am still. I haven't disappeared yet. Okay. No more power servers.
Okay.
Sure. I think that this is something that was particularly interesting coming out of the Latvia interviews, where they actually do have the products, but their registrations have been renewed because they can't find a stable market for them. So one of the things that we think might be a stabilization strategy is elaborating these markets for other indications so that it makes the market a little bit larger. But there is, of course, because we're dealing with these indications, the market is also related to the government context and where abortion sits, as Aisha talked about in Burkina, where there's increasing backlash. So I think that we'd have to look a little bit more into what might be possible.
Great. And the next question is, how exactly were the countries chosen? Can you repeat a little more information on that?
Sure. I can take, I think we had a slide earlier that talks about, we had preset some criteria. We wanted to have some countries where mifepristone was available, but not necessarily being used. I'll go back to the next one after this. Next one. There. So we wanted to have, we had decided to have 6 countries, and we wanted to have regional representation, including countries where no MIFI was currently registered for any indication and or limited legal abortion status or known interest in exploring MIFI for other indications. And we specifically wanted to include some countries where we knew that MIFI was available but not being used to its potential. We had hoped that, we anticipated that the global stakeholder interviews would help us hone in on some specific countries to move forward with, but as I mentioned in the summary from the global findings, it was a little bit of a mixed bag of where to work, but certainly West Africa was mentioned as a priority region. And so that's how we ended up selecting the 2 countries that met, and we knew that there had been some interest also in other indications in exploring the menstrual regulation indication, particularly in Senegal. So that's how we chose those two countries. And then we also knew that Latvia and Colombia were 2 countries where mifepristone, and Burkina as well, are countries where mifepristone is available, but maybe the market isn't optimal right now, and so potentially having other indications could be added. And Pakistan, we thought, was an interesting country to represent the South Asia region for regional representation, where we knew that there was a very active advocacy community around post-abortion care, and so we thought that it would be a good place to sort of capture a little bit of what's going on in that. Again, this is just a snapshot because we were stretching ourselves a little thin, perhaps with the 6 countries, but I think it was helpful in the end to have a little bit of a more global perspective to enable people to move forward with honing in on countries and regions of specific interest in the future and more in-depth level.
Great. And then the next question is the 4-pager available in French? And I think beyond that, in what languages is it available?
At present, it's only available in English, but we're certainly open to translation.
Great. All right. At this time, we don't have any more questions that are coming through. Jennifer, Laura, and Aisha, did you have any other things you wanted to add? Any final comments?
Just to thank everyone for their attention, and please feel free to contact us if you would like either a copy of the briefing document or the zip files with the associated literature review.
Great, and thank you all again for such a well thought out and comprehensive presentation. We will share the slides from today's webinar as well as a recording through the Safe Abortion Supplies workstream listserv. And as Laura said, feel free to contact her with any follow-up. Yeah, and thank you everyone. Oh, and one final comment, Milka has offered that she will be able to assist in the translation of the briefing document into Spanish, and perhaps that could be incorporated into webinar preparations for FORLAC.
Great, thanks, Milka.
All right, everybody, enjoy the rest of your day, and we will follow up with the information.
Thank you.
Thank you. Bye.